Welcome back, everyone. We hope that you have enjoyed our first set of panels. Next, we are ready to move to theme two. Theme two will highlight implementation science and specifically focus around evidence-based interventions to address climate health inequities. Our first panel within this theme will share insights behind implementing programs to address climate change, health, and equity at the community level and beyond. While our second panel will highlight research needs related to training and equipping a climate-savvy healthcare workforce and building a sustainable healthcare system through climate research. I am pleased to welcome Dr. Caitlin Rublee to moderate our panels and the Q&A session for this theme. Dr. Caitlin Rublee is currently an American Board of Emergency Medicine Fellow as part of the National Academy of Medicine's Fellowship for Health Science Scholars. Dr. Rublee is also an assistant professor of emergency medicine at the University of Colorado School of Medicine and the Colorado School of Public Health. She serves as the Director of Graduate Medical Education with the Climate and Health program through the School of Medicine. Dr. Rublee, I'll turn it over to you to take us forward.
Thank you, Shania, and I hope you all enjoyed your break because you are in for a real treat this afternoon. We are going to start our first panel with 3 speakers, and I will introduce each speaker prior to them sharing their expertise. We are going to hear from our community members. We're going to hear lived experiences and expertise within Indigenous groups and hear about what we're doing to guide leadership and transform a climate-savvy workforce as we move forward into addressing and not only recognizing, but rising up to the challenges that be climate change. So our first speaker is Shasta Gaughen from the Pala Band of Mission Indians. As a Pala Environmental Department's Director and Tribal Historic Preservation Officer, Shasta oversees the operation of the entire department. Her job is to make sure that Pala's environment, both natural and cultural, is protected. She works with legal and environmental partners on issues of importance to Pala, including fight to stop the Gregory Canyon landfill. Shasta, over to you.
Thank you so much, Caitlin, and thanks for the invitation to speak with folks. It's still this morning. I'm in California, in San Diego, specifically on Payumkawitchum Luiseño territory for the Pala Band of Mission Indians. I have worked for Pala for the past 19 years, and it's been the honor and the privilege of my entire career to be able to do this work for the Pala Band and also to work with other tribes throughout the United States. I am not myself Indigenous. My ancestors are settlers to the United States, but it's, like I said, been a huge honor for me to be able to do this work with the tribe, both on the environmental side and the cultural side. And those two things are actually inextricable when it comes to work with tribes. You cannot separate the environment from the culture. So when you're talking about addressing climate change, health, and equity for Indigenous communities, for tribal nations, there are a lot of things that need to be identified that are very different from what you might see in other communities that don't have an Indigenous focus on the land and that long time or time immemorial sense of place for the places that people have come from and where they live. One of the big projects that I've been working on for the last several years is what we call the Tribal Climate Health Project. And the point of the TCHP is to provide resources and technical assistance and advice to tribes when they develop their climate change vulnerability assessments and adaptation plans. But something we noticed when we started this project, and when I say we, I mean Pala as a tribe, but also my co-workers in this work, primarily the consultants from Prosper Sustainably, which is an environment and tribes focused consulting firm. I work specifically with Angie Hacker from Prosper Sustainably. She and I together had noticed that a lot of tribes had not been able to, or were not integrating health into their vulnerability assessments and their adaptation plans. A lot of people were rightfully looking at the environmental effects of climate change in terms of the potential for impacts from sea level rise, from higher heat from wildfire, from flooding. For our friends and colleagues in Alaska, we are talking about melting ice and changes to permafrost, all things that are environmentally focused, but not a lot of people were necessarily looking at or understanding the connection between high heat and health, wildfire and health, drought and health. And then from a tribal perspective, also looking at the connection between changes to the climate and the environment that have an effect on cultural health, mental health. So for example, what sort of impact might you have if drought and high heat are having an impact on a traditional food? Here at Paula, one of those traditional food sources is acorns, and they come from oak trees. And what we're finding is that high heat and drought and wildfire and pests are affecting oak trees, which means that you can't always harvest acorns, which means that you can't make that traditional food, the acorn mush called weewish, that is important for special occasions in a person's life, or in a family's life, or in a community's life. For tribes around the Great Lakes region, it's having an effect on the wild rice that they harvest and consume. For tribes in the Pacific Northwest, it has an effect on shellfish and regular fish. Regular fish? I don't know if the regular fish would like being called regular fish, but the difference between shellfish and fish. And they're impacted by harmful algal blooms in the shellfish. So there's the potential of consuming something that is part of your traditional practice, and yet it makes you sick. So what are those gaps when we're talking about climate change and health from the tribal perspective? And what we find at the TCHP is that the outsiders, the people who don't normally work with tribes, that's where we're seeing the gaps, where people aren't making the connection between perhaps somebody presenting with symptoms at an ER and understanding that this person who might be a tribal citizen from a tribe in the Pacific Northwest or the coast is being affected by eating contaminated shellfish, or somebody who has been using basket materials and perhaps those materials have been sprayed by pesticides in response to some sort of climate growth. And so these are the things that we're not finding in the research that we're trying to do to help tribes prepare for the impacts, and especially the health impacts of climate change. There is no data that shows how many tribes are able to specifically associate mental health distress with the inability to harvest a traditional food, or the traditional and cultural effects on an entire community if you can no longer go to a place where you used to have ceremony because it's been flooded and erosion has caused the paths and the ways to get to that place to disappear. There is an environmental impact that is directly related to the health of that community. So in trying to help our tribes that we work with find that data, that's where we need the help of others who are doing this work so that we can have more of an equitable lens on what those specific needs are for tribes and bring them in to our planning, into our planning process, into our adaptation planning, so that we can help tribes with those very specific needs that have a direct effect on both physical and environmental and then traditional cultural health. And that's all I have for now. So Caitlin, I'm going to toss it back to you for our next speaker.
Thank you, Shasta. I think a couple of things should cause us to think. And one thing that I heard is really incorporating health into vulnerability and adaptation plans. And then the other thing is really every region of this country is impacted, every tribe, and with all the different geographic locations, what are we going to do in order to address these needs through data and research to guide action across these different areas? So thank you. Our next speaker is Dr. Gabriela Lemus. She is with Maryland Latinos Unidos and is a passionate advocate for the Latinx community at their intersection of social justice and economic growth. Dr. Lemus's career spans more than 20 years in senior strategic leadership roles in congressional and government affairs, nonprofit management, policy advocacy, and community civic engagement. So I will go ahead and turn it over to you, and we look forward to hearing your presentation.
Thank you. Thank you so much for the opportunity to be here with all of you. As I was listening to Shasta, I kept feeling like, yes, 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 absolutely. I see that with the tribal research, but also with the Latina community across the state of Maryland, where I'm located, but also across the country. Just a little background on Maryland Latinos Unidos. We exist to call attention to the disparities and inequities faced by Latina communities and immigrant communities. And we don't just call them out, we also try to find solutions and to address these challenges with coordinated action through convenings and conversations, and bringing, building networks of folks in key ways that might be unusual, in the sense that oftentimes our work is very cross-sectoral. And I'll discuss a little bit about that in terms of the research. We have a vision, and we were born out of COVID, and our vision is a world where your zip code does not determine your lifespan. And we feel very strongly about that. And big part of the reason that this work has been taking place is in large part because Maryland, the Latino community here is pretty new. Really, it's only been in the last, probably since the 1980s, that we've seen a fairly large expansion. There was an early arrival group in the 1960s from Cuba primarily. Maryland is traditionally a receiving state for refugees and asylees. But this new community is very different, and it really came out of civil wars in Central America. Many of the folks here are primarily Central American, unlike parts of the Southwest where the large majority of the community is of Mexican origin. Can we go to the next slide? So when we got involved in environmental health, as we call it at Maryland Latinos Unidos, we're a little messianic about it, because what we really were looking at were social determinants of health overarchingly. And the issue, just as Shasta said, related to health and the environment was just not connecting, and hasn't been. And one of the things we even saw during COVID was that the environmental impacts impacted the health impacts on folks, and really made things quite difficult. So our challenge from the perspective of climate change is that we recognize that climate change poses a number of health risks to our communities, from threatening our human safety, right? Fires, wildfires, or big storms dumping a lot of water and flooding us, basically threatening our human safety. But it also has had impacts of worsening health conditions, and even going so far as jeopardizing our food, air quality, and water supply. So our goal has been, and I feel like this is such a wonderful venue, because it's really to develop the knowledge that Latina communities need internally in Maryland, but also nationally, to adapt and reduce further harm from adverse health impacts, but also from that impact from climate disasters. Next. And this next slide is, it's not mine, and it's a cancer slide, technically speaking, because it comes from the American Cancer Society. But what I found very interesting about it, it really gives us a sense of how things interact and the ultimate health impact it has on the Latina community. The first is exposure to ultraviolet radiation. Ozone depletion. We know that it allows more harmful ultraviolet radiation to reach the earth. That means we have to be conscientious about things like SPF and clothing and heat indexes, etc. We also know that the Latina community has higher exposures to air pollution, and, well, maybe not so much that they have higher exposure to air pollution, but that we have certain chronic conditions related to air pollution, from Puerto Rico all the way across to Los Angeles, where our asthma rates are way disproportionate compared to other communities and other parts of the country, but also our other respiratory conditions like bronchitis, et cetera. And lung cancer has been increasing slowly in our community as well. In terms of exposure to wildfires, the recent Canadian wildfires really brought it home for me. My staff member has asthma pretty badly. She's a single mom and she has a little boy. Her son has asthma as well. And when the fires from Canada came last year, I guess it was June, and the air quality started changing really badly. It really, she couldn't even go outside. She kept having little asthma attacks. And here's this single mom who has, luckily she can work from home if she needs to, but most of our community doesn't have that privilege. And she works remotely, but she can't do her real job, which is local organizing. She goes into communities. She's our frontline person. She has to talk to the workers who are being exposed to let them know about how to adapt and build resilience when they could possibly, become impacted by this wildfires and this air quality. What we also know is that heat indexes rise during these events. And August in Spanish language media here, Telemundo refers to August as ozone month here in the DMV, DC, Maryland, Virginia area. And so everybody knows, be careful in August, don't go outside, try not to. Well, what does that do? We have a lot of concentrations of our workforce are outdoor workforce. We see a reduction in physical activity. As I just mentioned, my staff member cannot go outdoors and exercise. Her son is caught indoors. How does that affect her indoor air quality? Because that's something also that we have to think about. And of course, when we see increases in these kinds of ozone challenges, we also tend to see an increase in particulate matter. And this is a big question, especially in our industrial park areas, diesel trucks, et cetera. Maryland has done a number of things like passing legislation to allow for electric school buses, for example, so the children aren't exposed. But there is nowhere near enough information or connectivity between the events themselves and this underserved community in the state. Next slide, please. Which gets us to the research gaps, which is what we've been talking about, right? And so what we do know is that positive outcomes come out, are possible, right? Behavioral changes are possible when the adaptation pathways are accessible and make sense to us. Meaning, what I said at the beginning, we know when the UV radiation is more challenged than other times of year. August is ozone month. Make sure folks know about what kind of clothing they should wear. Be aware of heat index gaps. This was a big problem in our local community. Let's just start with my county. My county didn't do any local health department warnings in Spanish. So there's language barriers, there's access barriers to services. We had a number of workers last year who got very sick, and one passed from just overexposure, but also he overheated and he wasn't hydrated. And that lack of information becomes a public safety issue, especially for the workforce. So in this case, it would have been ideal had the statewide labor department and the local health departments and the statewide health department come together with a media message, but also translated it into Spanish and shared it in such a way that made sense to the community. There's very little research on what's going on along the eastern seaboard from Maine all the way down to Miami, for example. This is a big research gap for us in our community. We also have issue area research gaps. We know Latinos are disproportionately impacted by air quality and have asthma, like I said. But something we also know is they're more likely to have drinking water that doesn't meet federal standards. And Maryland has a very active Chesapeake Bay community that is very much about keeping the bay and the watersheds clean. However, they're not really looking at the impacts on local communities, especially in some areas which are unincorporated that are located around our watersheds, like at the Anacostia River area, and in Prince George's and Montgomery counties, which happen to be, both of them are 21% respectively Latine. So the Latinx community is one being exposed, two is not getting all the information that they need and therefore unaware about the changes they could make, like buying filters, for example. And I'll talk a little bit about that in the next slide. And last, investment in cross-sectoral impacts by health departments themselves, but with other agencies. We do a lot of local advocacy work. So I not only work with the state legislature, I also work with the county executive offices and the county councils and municipal councils and city councils, because there are important pieces of legislation occurring in each and every one of them, but we don't have the data. We don't have the information about how. I had a long discussion with our data quality control person for the local health department, for example. I'm a health commissioner. And we don't have, they would have to get the county executive to request the funding and then get the county council to approve the funding. We would have to advocate for it. It's a whole process, the same way at the state level as it is at the local county level. And so all of that has to be informed with information that is related directly to what is happening in our zip codes. And we don't have that. We don't have that. We don't have the investments being assigned, but we also just don't have the research. This is, again, really important for those of us who work outdoors in construction, landscaping, road work, et cetera. We recently saw the tragedy of the Baltimore Bridge collapsing. What you don't know is that at the same time as that, all that reconstruction is taking over, having to take place and restoring our regional economy, at the same time that is all happening, those Latino workers are representative of all the peoples in that area who are being hired, because we don't have enough people in our state, who are being hired to do the new funding work that's coming in, funds coming in from the federal government to do green infrastructure, to build those locations for electric cars, for example, so that they can charge, who can take care of the new kinds of roads we're trying to build and the changes in the utilities system, right? The grid. All of that requires Latina workers. So I go to my last slide, highlighting the mitigating the impacts. And what we know, very briefly, we know we can all have the power to make change, but it's really important to have that research and that reliable information, because that will inform the choices that we make, the food that we choose to eat. Is it, are we eating more locally grown in foods? Are we bringing in foods from far away? The types of products that we purchase in our homes, we paying attention to our air quality inside our homes, given that outside, we know there's these air quality impacts, and the water that we're drinking, are we getting filtration? And even within the healthcare system itself, there are choices. And this I learned for a conference that I did on cancer and climate. We really talked deeply at this conference about the quality of food being served in the hospitals and making choices at the hospitals to ensure that we are having a sustainable food system, but also petitioning for better infrastructure in our healthcare settings, because this is part of what we have to learn as a community. Our median wages are considerably lower than that of the states. So, for example, we make $50,000 median wage per year per household compared to $70,000. It's $35,000 at the national level. So, we're doing better here than we are nationally, but we're still well below. So that means we have a lot of challenges related to housing, where we can live, what's available to us. But in order to get to that point where we are petitioning for better infrastructure for our healthcare settings, we have to understand how we can be resilient and adapt. And for that, it requires really powerful research and information. And now my last slide. And with that, I thank you. Le doy las gracias. I appreciate this opportunity. And if there's any questions, please feel free to ask. This is our web, mdlatinos.org. Back to you.
Thank you so much for sharing your insights. And I think the vision that you have is shared by all of us of living in zip codes where those do not determine our lifespan, and what does a healthier, more equitable community look like within the Latinx community and across our country here. All right, we are going to circle back to our third speaker and transition to our second panel, which is training and equipping a climate savvy healthcare workforce to build a sustainable healthcare system through climate research. Our first speaker is Dr. Ed Maibach with George Mason Center for Climate Change Communication. He is director of Mason Center for Climate Change Communication there and a principal investigator of the Yale George Mason Climate Change in the American Mind Polling Project, among numerous other projects. He is a co-developer of the Medical Society Consortium on Climate and Health and is a member of the National Academy of Medicine as well. So without further ado, Dr. Maibach, we welcome your presentation.
Thank you, Caitlin. Delighted to be with all of you today. I'd like to focus my comments on my meditation on a specific aspect of what it means to be part of a climate savvy healthcare workforce. And that specific angle is, all of us in health and healthcare, we have our jobs, but we also have the things that we do above and beyond our jobs. And one of those opportunities that we have to exhibit our climate savvy and really to get the most leverage on addressing climate change as a health threat is the fact that we are trusted. Healthcare professionals are the most trusted category of professionals in America and around the world today. And that gives us this extraordinary opportunity, not only to be more adept at addressing climate change through our work, but it gives us an opportunity to to get to root causes of climate change and to affect solutions to climate change in the broader communities of which we are all embedded. And so it's that trust that gives us, I like to think of trust as our superpower, if you will. That's how we as health professionals really can get the most leverage on helping to move solutions forward. In my research and the research that my team does, we've done a lot of audience research with health professionals. We've also done a lot of research with members of the public. And there's this wonderful confluence between the high degree of concern that health professionals in America and around the world are showing about the issue of climate change and what they can share about that concern with members of the public and with policymakers at the local level, in their state houses, on Capitol Hill, and in our White House, and in parliaments and other national capitals around the world. The research is really clear that when people know very little. When I say people, I mean both the public and policymakers know very little about the human health relevance of climate change. But when we share that, when we, health professionals, when we share that information with members of the public and policymakers, it opens up a new lens, a new aperture on the problem that most people had never considered before. And the beauty of opening up that new lens is it reveals to people a degree of personal relevance to the issue of climate change that most people had never considered. It really is one of the most powerful narratives that my research team at our Center for Climate Change Communication has ever tested. Climate change is a lot of different types of issues, but when we talk about it as a health issue, it has this almost magical quality to heighten people's engagement in the issue and build their sense that this is an issue worthy of our address. This is an issue that we individually and we collectively need to do more to address, to solve. So the trusted voices of health professionals have this extraordinary opportunity. I guess I want to end with two reflections on what research is really needed to take advantage of this opportunity. Firstly is our research with our surveys and other research with doctors and public health professionals and nurses has shown, as I said before, very high degrees of concern about climate change as a health issue, very high degree of recognition that it's already harming the health of my patients or the people in my community, but at the same time, a very humble reflection on how little they really know about the problem. So what we see out there in America is a healthcare workforce that understands climate change is a health issue, but feels ill prepared to deal with it. So I'd say that's the research challenge number one, is how do we rapidly bring not only our trainees, but frankly, the healthcare workforce who's in the job today, how do we bring them up to speed quickly on understanding the causes of climate change, the health impacts of climate change, the opportunities that we have to try to mitigate the problem and become more resilient to the health impacts, both in their work as health professionals and in their broader role in the community that I've been talking about, their role as a public educator, and frankly, their role as a policy advocate. So how to bring this concerned healthcare workforce up to speed rapidly, I would say that is the research gap number one that I would like us all to focus on. And then in closing, I'll point to a second gap, and I actually think this is perhaps a gap that the National Academy of Medicine is uniquely qualified to help us address. And that is, I've been in the public health workforce for 43 years now. In most of that time, I have looked at tobacco as the leading avoidable cause of premature death and disease. Over the past 5 or 10 years, however, I've come to recognize that that mental model I had as a public health practitioner was out of date, because in fact, I'm quite convinced, based on what little evidence I have access to, that the fossil fuel economy and the climate change that it is causing are actually the leading preventable cause of premature death and morbidity, a range of acute and chronic illnesses. Yet, when I said I have access to relatively little data to prove that point, it's because relatively little research has been done to quantify the health impacts of climate change, the health impacts of the fossil fuel economy, and the healthcare costs. I mean, health is about health, but ill health creates healthcare costs. So we have not done a very good job of accounting for the health and healthcare costs of the fossil fuel economy and the changes in the climate that is creating. I would contend that that is possibly the most important research gap that we need to find a way of addressing as quickly as possible. So Caitlin, let me turn it back to you. And again, thank you for the opportunity.
Thank you, Ed, for those incredible insights. I think this is an issue worthy of all of our time and energies as we move forward. And as we've heard all day, there are so many research and implementation opportunities to move forward. One of the things you mentioned was training the next generation of savvy climate workforce, health workers. And with that, I think it's extremely important to hear from physicians and nurses, people who have the lived experiences within hospitals and clinics caring for patients and communities. And so our first speaker to provide his expertise and remarks is Dr. Jay Lemery, who is a professor of emergency medicine and the Climate and Health Foundation Endowed Chair in Climate Medicine at the University of Colorado School of Medicine. He serves as chief of the school section of Wilderness and Environmental Medicine and is currently the medical director for the National Science Foundation's Polar Research Program. He is also a member of the Council on Foreign Relations and is a member of the National Academy of Medicine. Dr. Lemery.
Thanks, Caitlin, and great to see friends and new friends and share some of our work. We think about research challenges, and I think what goes hand in hand with that is our educational mandate. So we leaned in hard to think about how do we scale up a climate savvy healthcare workforce. And the reason is that we looked at the ability for healthcare to mobilize and implement policy and realized that this is really complicated and none of us are trained to have that facility, to, as I wrote, effectively articulate that dizzy interplay with all these different things that are well beyond medicine, but affecting health, energy policy, geopolitics, earth science, government, and medicine. And so when we thought about what competencies could look like, how do we scale this up? And we started with physicians, but have since broadened it to all healthcare providers. We envisioned this phrase of climate medicine, and it's medicine in the large sense, which is really how do the clinicians lean into this? And so it's an aspirational phrase. We're still defining it, but we realized, hang on. Sorry, I didn't turn off my some discoverable on FaceTime. So we realized that climate medicine practitioners were a trusted resource, can credibly address the deep-rooted environmental justice issues and convincingly explain. And all this is to say that they're leaders. We wanted to build leaders in the field. We started off doing this in 2017 with one clinician a year, have since expanded it. And our core competencies have expanded just beyond knowing situational awareness, again, to these other higher level skills of leadership, and really having a 360 around this issue. Next slide, please. I love this because I'm an emergency physician by training, and this is how we started it. And it was very much because I knew how to start this in emergency medicine. But as we gained more aficionados and other stakeholders, we've expanded it. And now we've expanded it to include all of these different medical disciplines, which it has to be that way because this is an all hands on deck situation. So this year we've added palliative care, peds, radiology, because they know so much about how healthcare or hospital systems work, and decarbonization, neurosurgery and neurology, because as they said to me, it's all about plant-based diets, dude, and cardiovascular risk, and thinking about what a meat industry does, the impact, the carbon impact it has on the world. And we've also been able to leverage our relationships and our network to have our fellows precept at 5 different federal agencies. You can see them here. As well as 5 different nonprofit partners, NGOs working in the field. So this again is a jobs training program where they come out with a robust network. They've seen how policy gets made in government and in the nonprofit world, and so that's all part of how we've crafted this. Next slide, please. But I got a phone call saying, hey, I'm a dermatologist in Tampa. I have 3 kids. I have a booming practice. I'm 10 years out and I can't do your darn fellowship. What do you have for the rest of us? And it was a really provocative question because, one, we knew we had to expand beyond physicians, and we had to make room for other healthcare providers. And we had to do it in a way that people could engage any point in their training. The fellowships are early career by design, but there's so much talent seeking that credibility and those opportunities to, in fact, be leaders. And we had to create that. So next slide, please. So we envisioned a heavyweight credential. And I say this because we were in it. There are many one-day seminars, and that's so important for dissemination. But we said, if we're going to do it, let's leverage the assets that we have, through our fellowship, and go deep. And so we created a diploma in climate medicine for healthcare providers. It's 300 hours. Again, it's a heavyweight. It's meant to be, it's non-matriculating. So there's no, it's a credential from the School of Medicine, but there's no issues with having to matriculate. And we've done it in, asynchronous and remote and in person. So it's a bit of a hybrid. And, we thought about, okay, what would it look like? And this was meant to give the clinicians a 360. So we talked about foundations, healthcare system, sustainability and resiliency, disaster response, energy policy and healthy communities, and then grand challenges of displacement and sea level rise and geopolitics, with climate justice, communication, and leadership sort of embedded in. So again, I put this out here because these are the things that we felt we had to start on. We were hopeful it would be replicable for our colleagues in any educational endeavor, and we're still learning. Hence the need for research in this. What are the outcomes? Well, we're doing some research, but man, it would be so cool if there was a multi-center research where we could actually track our graduates and our diplomates through many different institutions as we scale this up. Next slide, please. One thing we've realized is that one of those courses within a diploma is very specific, and it's almost, if you can go with me on this, it's hard skills, where a lot of these other things are intuitive to a healthcare provider and you can teach them pretty easily. It's another thing learning scope 1, 2, 3 carbon emissions, how to account for that. And then some of the very particular issues around carbon accounting and sustainability science. We think that this is really going to blow up as an offshoot when you consider the position of HHS and CMS and the Joint Commission suggesting that this sustainability metrics could be linked to healthcare system reimbursements. They're not yet, but there's some evidence to suggest that that's happening. Who's trained to do this? How do we interface as healthcare providers? How do we put that patient-centric face on these things? And I think this is an area ripe for pedagogical innovation and research. Next slide, please. And particularly, we know that healthcare leaders, right, who are in the positions of CEO, there's a valley of death to overcome because the metrics that they get are so idiosyncratic. And even if they have the aggregate data, how to make informed decisions around that and sell that to a board or patient stakeholders or so forth. And it's challenging, it's formidable. And what we have seen with AI is that the potential to take big data sets, separate signal from noise, and have meaningful, actionable outputs at the end, and really be able to make those linkages that are necessary to say, hey, if we put up solar panels or we recycle in this regard, we'll see the most bang for the buck. Because that's what we need to do. We have sympathetic people in the C-suite, but their margins are so thin that there's a real disincentive to move. So as I socialize this idea, as we talk with our teams and other groups within the Action Collaborative with the NAM, we think about, what are the metrics and the implementation science, including AI, that could help get us over this barrier and make this a much easier thing to do for decarbonization efforts. So with that, I think that's my last slide. I'll turn it back over to Caitlin, and I'm excited to talk more.
Thank you. Our next speaker is Dr. Beth Schenk, and she is an Executive Director of Environmental Stewardship for Providence, leading a cross-functional commitment to reduce operational pollution while addressing environmental justice and climate resilience in the communities we serve. Dr. Schenk has been a Providence caregiver for over 30 years, from serving as a nurse in the intensive care unit in Missoula to leading nurse research across the Providence organization. Dr. Schenk has nurtured her passion for environmental care. Over to you.
Thank you very much, Caitlin, and I'm delighted to be here with all of you. And if you don't know much about Providence, we're a large health system in the Western United States with 51 hospitals and over 1,000 clinics. We have 120,000 caregivers, which means employees. And the way I count these, about 90,000 are licensed or registered clinicians or ancillary clinical staff. I work specifically on environmental stewardship, and we're doing a lot on several fronts every day in the trenches, in the data, working to reach thousands of people. We address mitigation by trying to reduce our greenhouse gases and other aspects of pollution or misuse of resources. We work on adaptation and resiliency by addressing our own infrastructure readiness, clinician readiness, and our community partnerships to help with adaptation and preparedness there. And we work on advocacy through sharing our voice as a large health system and encouraging more and more sharing our voice as individual clinicians. We address elected officials, also professional organizations, partner organizations, and other health systems. So as someone in the field doing this every day, I'm really interested in pragmatic research that supports change and action. And for the questions, the two questions of this panel, climate savvy workforce and building sustainable systems, I'm thinking in two different directions here today. So first, clarity about the specific clinical practice to decrease carbon emissions and increase sustainability. We know a lot about this. We're learning a lot more about it. As Jay said, our sustainability science is growing and it will continue to grow, but there's a lot of questions there that we have to come up with again every day, and we just don't have evidence when we try and make decisions. So I'm just going to list a few of those as ideas. Unintended impacts to the planet. This could come from product use. This is addressed currently by LCA's life cycle assessments, research and design for better materials because of our plastics crisis, the volume and extent of products used. What else can we do that's better? From clinical policies, for instance, infection prevention, a lot wrapped up there, length of stay, lab testing and imaging frequency, sort of a choosing wisely approach, telehealth, preventive care. I keep reading anyway about the baby boomer bulge now, we're going to be dealing with geriatric and end of life practices for the next 2 to 3 decades significantly. And what can we do to understand the impacts to the planet while also insisting and ensuring compassionate, ethical care? Another angle to think about is comparison of harm. So this is a good place to discuss infection prevention practices. We know that we're reducing harm by avoiding infection. Unfortunately, we're also adding to harm by an abundance of resource consumption, probably excessive energy use in unnecessary air exchanges, but those data are not clear. So I'm really thrilled that there's starting to be more discussions, open discussion about that. I think the pandemic sort of helped us because we saw the overwhelming resource use. In healthcare, our default to single-use disposable devices. There are more and more options and alternatives, but if we understood impacts better and could report that more clearly, I think it would be easier to make change. Menu planning and serving to move away from beef, primarily rich foods. Sources and generation of energy and what they mean for health. This is something clinicians don't know much about, but I think we need to have at least some level of education. And for that, we need to understand clearly, and there's a lot of obfuscation out there. So this is an important area for us because the next 30 years are going to be energy transition. Manufacturing of and exposure to chemicals of concern in the workplace. We get 700 new chemicals a year, mostly not tested. A lot of work to do there. Okay, so now switching to the next question, which is understanding best methods to prepare a climate savvy workforce. How to reach and motivate clinicians of all disciplines. The primary theme is TLDR. Honestly, I don't think people read much. It's so much stuff coming at them all the time, it's just too much. So how can we do that better? What's the ideal length of messaging? What's the most effective structure of messaging? What do we need to make sure we include to keep it simple, to include motivational reasons, just the facts? What's the best way? How do we measure success with different surveys? The ones that Dr. Maibach is working on, and another one, Chant, that I have been working on. How do we get known results from past and current research out to clinicians more quickly? People tend to read their specialty journals, I think. And so if there's a way to do quick take-home points with calls to actions that clinicians can respond to fairly easily, that would be helpful. And another area of thought in this bucket of climate savvy is how do we help people move from overwhelm to action? And I say that because of the Chant survey, in which we have questioned healthcare professionals since 2019. One of the segments we ask about is what motivates you for action on climate and health and what demotivates you. And every year so far, the top answer, the most frequently answered option for the latter, why people don't act, is that I'm overwhelmed. So what can we do to help with that? Because yeah, I understand being overwhelmed, but also my experience, you break it down, you take things one at a time, we can get through things. So what can we do with that? And the best ways to motivate action, if we had some insights, this might help. Should we appeal to professional obligation, to the health of patients and families, to love of the planet? How do we make it easy? What are the most important or effective actions for busy people to take? If we could have some idea about that, I think we could tell that story effectively and also make it easier. How can clinicians of all disciplines most effectively use their voices? And what are effective ways to engage them in action? Should we pay them? Should we make it easy using various platforms? How do we check in with them to see who they are talking with, who they are sharing this with? Do we need more news and stories about how clinical people are making changes? And lastly, How do we support and protect the mental health of healthcare professionals regarding climate change? It is overwhelming. Jay's last slide reminds me of the gulf that we are walking through and had ahead of us. We are asking clinicians to do a lot right now, and they're already dealing with suffering and stress every day. What do we need to do to build into best practice for clinician self-care and the care of our teams? They are often overwhelmed, as we have some empirical data for, and potentially somewhat paralyzed. We don't know that for sure, but we need to figure out better ways to engage and motivate. So I look forward to the research results that others will be generating that we will try and use. So thank you so much.
Thank you. I love how to make it easy, right? How to make it easy for messaging, for connecting to audiences, and most importantly, connecting to our communities and patients who have the most to benefit from any of our interventions. So thank you. Our next speaker is Dr. Renee Salas, who is an emergency medicine physician in the Department of Emergency Medicine at Massachusetts General Hospital and Harvard Medical School. She is affiliated faculty at the Center for Climate, Health, and the Global Environment at Harvard T.H. Chan School of Public Health. She has led numerous endeavors with the world's top medical journals, including the New England Journal of Medicine, as well as the Lancet Countdown on Health and Climate Change. She was elected to the National Academy of Medicine in 2021 for her incredible work, and we look forward to hearing your thoughts on addressing and upscaling a climate-savvy health workforce and what we can do within our communities.
Well, thank you so much, Dr. Rublee. It's been wonderful to learn from my esteemed colleagues on this panel, so thank you to each of you. And it is an honor to be invited to share my perspectives and work, especially those rooted in my experience leading the Climate Crisis and Clinical Practice Initiative with the New England Journal of Medicine Group and the Lancet Countdown US Brief Working Group. So I plan to first discuss the research gaps that exist for adapting and improving clinical practice in healthcare delivery. And then second, I'll highlight how data and indicators can not only guide which people and communities are at greatest risk, but also help us understand which interventions are most effective using monitoring and evaluation. So first, as you've heard, there is a clear consensus on the urgent need to protect the health of all patients, and especially those who already experience health disparities from structural and systemic racism and income inequality. But this challenge also presents an opportunity to leverage clinical practice and healthcare delivery to find solutions that will improve patient care and strengthen community resilience to climate change. For example, as I outlined in the 2020 New England Journal of Medicine perspective that launched the Climate Crisis and Clinical Practice Initiative, I treated an elderly gentleman whose wife called 911 because he appeared confused. Now, the EMS crew said that when they got there, they felt like they were hit with heat from the Sahara Desert when they opened the couple's door. And living on the top floor apartment during a record-breaking heat wave in Boston, they didn't have air conditioning. The patient's core temperature was 106 degrees Fahrenheit, the diagnosis of heat stroke, the most life-threatening form of heat illness. Now, how could we have prevented his heat stroke in the first place and improved his care? I outlined possible adaptive improvements we could make to clinical practice, such as adapting triage protocols or patient screening and clinical interventions, but little supporting evidence exists. Now, one important study in PNAS that I cited shows the importance of regional and local data to guide practice. It found that hospitalizations for heat-related illness occur at lower heat indexes in traditionally cooler parts of the country. For example, the Northeast, this occurs around 85 degrees Fahrenheit compared to 105 degrees Fahrenheit in the South. And why didn't the couple access a cooling center? While cooling centers are commonly recommended interventions, we actually have limited evidence on their effectiveness, and often those who need them most can't or don't access them. Research is also needed into other ways that vulnerable patients like this couple might avoid excessive heat exposure at home, like the provision of air conditioners and energy assistance. Should his high blood pressure medications have been adjusted because they put him at greater risk for heat illness? If so, how? Again, here data is lacking to guide this clinical question as heat exposure intensifies. Another key climate exposure is poor air quality from threats like fossil fuel-related air pollution, climate change-driven wildfire smoke, and climate-intensified pollen. As my colleagues and I outlined in a clinical update for the British Medical Journal, there's limited evidence for interventions like high-risk patients wearing N95 masks outdoors on poor air quality days, or the use of preventive medications for those with lung disease when the exposure to poor air quality is anticipated. Now, these are just a few examples to highlight the broad gaps. A series of reviews in the New England Journal of Medicine, on which I serve as guest editor, suggested clinical practice and care delivery interventions for different climate-related exposures, but these have to be rapidly supported by research. Data are needed to not only support a range of strategies for climate adaptation, but also for tracking to identify the critical areas like who is at greatest risk within a community, and to monitor and evaluate the effectiveness of interventions and improve them where needed. Now, these lessons are drawn from the Lancet Countdown, the global leader in tracking the connections between public health and climate change through indicators, which are just data that measure the state or trend of a targeted condition. Now, indicators can be the number of emergency department visits, hospitalizations, and death for heat at different levels of resolution, and local scale is especially important to guide and evaluate local implementation. So as two examples, our recent research paper in Nature Medicine outlined a methodology to track ED visits, hospitalizations, and mortality in patients that are covered by Medicare following exposure to short-term climate-sensitive billion-dollar weather disasters, including floods, severe storms, tropical cyclones, and winter storms. But beyond health outcomes, indicators can track key intervention pathways across areas like practice changes, policy, finance, and public engagement, which are important for changing systems at the large scale. For example, given the importance of research funding to support the gaps that are being highlighted across these presentations today, my colleagues and I published an external tracking mechanism that could assess a very restricted definition of extramural federal research funding at the nexus of climate change and health affairs. So in conclusion, facilitating research at the scale and speed required to address the health impacts of climate change mandates a collaborative and coordinated response across public health, medicine, communities, government, other disciplines, and beyond, as you have heard. But this means elevating existing work and initiatives, bringing researchers together from across disciplines to enable novel integrations of diverse data streams and research designs, and further investing and expanding in research capacity. An upcoming national endeavor is inspiring to help drive this for clinical practice and healthcare delivery, so stay tuned. But thank you for your time and attention, and I look forward to our discussion.
Thank you. All right, we are going to circle back, and we have one final speaker who is having a bit of technical issues earlier, but it almost seems on par to conclude with another Climate Communities Network member, and that is Raymond Sweet, who represents Hollygrove Dixon Neighborhood Association. Raymond is a professional working at the intersection of child welfare and environmental sustainability, with a primary role as a voluntary recruitment coordinator for court-appointed Special Advocates New Orleans. Raymond is committed to advocating for the rights and well-being of children in foster care. So I will turn it over to Raymond, and then we will have a few minutes to address some questions with the panel.
Greetings. I hope you all can hear me well. I am living in the city of New Orleans, Louisiana. At the moment, I am in the great city, I guess the state or country of the Netherlands. We are here to study how they process or manage stormwater in the Netherlands, and we want to bring some of that information back to the city of New Orleans. So that's why I'm here, and it might be the crux of some of my technical issues, I'm not sure. So with that said, our biggest issue, or one of our biggest issues, is the urban heat island effect. We live in a very impervious community in Hollygrove, Dixon, and we have members of our community who have a disdain for trees because of the calls that it has on our piping systems, the fact that it may fall on a roof because of our other issues, and that's hurricanes and wind and other storms that are more frequent in our city of New Orleans. And so the thing that might help us with the thing that we're having a problem with is also a problem. And so we are attempting to educate our residents on the value of trees and how they would help reduce some of the urban heat impacts that we are having in our community. The reality of it is that a $300 electric bill because of air conditioning, they have air conditioning in the South, but you were saying in Boston they didn't even have an air conditioning. We have air conditioning in the South, but when you're faced with the potential of a $300 light bill, you may not be willing to do that. And so how does this impact a person's activity? Do they cook less at home, which means that they're going out to eat, which means that their food that they're eating when they go out has more salt in it, has more saturated fats in it? And are they getting less exercise because it's hot, because they don't have a cooler environment to walk in? So all of these things are a part of our understanding of how the urban heat island effect is really taking a toll on our little small BIPOC community in New Orleans, Louisiana. And then the other issue that I have an anxiety with about this, we talk about research and not having enough of it. We know that research says that it's cheaper to educate someone than it is to imprison them. But we spend a lot of dollars imprisoning folks and very little in educating them in the South. And so one of the anxieties and frustrations that I have decided to have before I even return back to New Orleans, Louisiana, if we get all of this information and all these great ideas, and because I work with a collective that writes grants, we bring money to the table, will the government and those powers that be actually implement those things that requires their participation? And so the actually do better is the question. And so that's one of the issues. I'm freezing right now, I'm sorry. That's one of the issues that we're facing in our communities. We have folks that have access to all kinds of information, all kinds of data, and we know that these things, the things that we do have information about works, but we have a hard time convincing some of our leaders who have access to resources in the South. We don't have millionaires like they might have in Los Angeles, that may have in Chicago, that might, be so us these dollars to do this. We have to rely on tax bases and dollars from the government and encouraging the government to apply for dollars that are out there and not being using money as a way to punish people in our BIPOC communities, but accessing those dollars and not saying that we won't take federal dollars because we are being proud Americans. We have information, we have data. The problem sometimes is how do you convince those people that are in charge to do what the data says, to put their money where the data says the money should go and not in some other places. So those are the frustrations that small communities in the South like mine face, fighting an uphill battle, trying to get dollars placed in places that it belongs and not in places that it does harm. So I thank you guys for your time. I'm glad I was able to to make it in, and thank you guys again for all of your hard work.
Thank you, Raymond, and safe travels to you. We wish you only the best. All right, we'll transition to the question and answer component for the next 10 to 15 minutes or so. We have until 2:40, and then we'll transition to break. So thank you to those who have already sent in questions. Feel free to post more and we'll answer them as best we can. So this first question is for Shasta and Gabriela. What can we do to better support or invite and welcome communities and their members into co-created transdisciplinary research? So I'll go ahead and start with you, Shasta.
Thanks. And to be honest, that's not the kind of question I usually get. So my brain kind of froze for a moment. But I will say that when it comes to working with tribes, you have to approach them with the understanding and knowledge of what their relationship is in general with larger systems and that they're embedded within. And the most important of those is acknowledging tribal sovereignty. Tribes are nations, and so their members are citizens of those nations. Whether we're talking about federally recognized tribes, which is a special relationship between those tribes and the federal government, but also non-federally recognized tribes who have citizens that still have traditional culture and practices and things that are important when it comes to managing climate change and health. So how do you bring them in? It's a difficult thing to do, but you have to start with making sure that you are extending a respectful hand to them that allows for the tribes themselves and the people within those tribes to have a lot of control over the work that they do with outside institutions and agencies. I'm an anthropologist by training, so it's been my life's work to have that kind of relativity coming into a tribe or a culture to try to understand things from their point of view. And if you come in with this idea of how things should be, as opposed to being open to listening to how things are in those communities, then you're less likely to have success. And tribes have had lots of bad experiences with their medical data, their health data, their cultural data being used in ways that actually ends up being harmful to them. So having a co-space like that, it really starts with developing relationships and letting the tribes take the lead. I could probably give an hour-long talk on this, but I don't want to take up all the time. So I'm sure Gabriela has good points to make on this question as well.
Thank you, Shasta and Caitlin, for the question. It's kind of interesting because as I'm listening to you, I'm having it's resonating with me very well. We've learned a number of things. We do a lot of work with local health departments, for example, related to how to better communicate with a bilingual community that is also multicultural, to possibly a Spanish dominant community, and three, a community that we call, once you come to the United States and if you come from Latin America or Central America, you're automatically Latino or Hispanic. And we have a number of groups here, Mayan origin groups, for example, who are living in the area who do not consider themselves Hispanic or Latine, but get bunched into our grouping. So I think there's a number of things to understand. One is that Hispanics, Latinos, Latine are very, very diverse. We're Afro-Latino, we could be mestizo, meaning, a blend of indigenous culture and Spanish descent, but we could also be literally European. Something we don't know about Mexico, for example, is that many of the settlers there were from Czechoslovakia, Belgium, Lebanon, and I was going to say Germany and Czechoslovakia, bringing the beer and the oompa music, but also just a different diversity of how we look, right? Ireland even. Anyway, having said that, we learned a lot of lessons in working with our local health departments. We've learned through community surveys, and this is something we would encourage the healthcare systems and public health systems to consider, especially as you get into research, is there's a lack of confidence in the security of documentation, period. Our Latinas in the area demonstrate a serious concern with data collection from in large systems and how that impacts them. It goes a step beyond just the simple distrust of the big system, the healthcare system, the public health system, the government system, to actually the data collection system and how it's being housed and the privacy. Another lesson we learned is that a lot of our organizations, whether it is a healthcare or healthcare department or public health department or government agency, or nonprofits, even though they're supposed to meet the needs of the community and of Latinos and immigrants, are not prepared to do so. They either don't have sufficient staff, or they actually don't have staff who are bilingual and engaged, what I call culturally responsible, right? That understand the diversity and how folks communicate. There is a fear and dislike of government aid, for example. So when you are looking to see whether or not they have certain government programs, even when they're entitled, let's say for maternal health, they themselves will not approach it. Even irrespective of whether they are citizen, second generation, or more recently arrived, an asylee, all the way up to temporary protected status, or even an undocumented person. We know that when we come in with an attitude of inclusion, and that it's about community building and trust, and we come in with that good attitude and we let them tell us what they need, it creates opportunities. It means that's when you start seeing the clicking, when they start not only understanding what you're explaining, but they're also like the trust starts, right? And then, we have to ensure that as we educate ourselves about, what is our health literacy around the environment, that we're also building language and cultural access, as we explain it to them as the community members. And lastly, I would say when we start to gather information, we have to be willing to be a little flexible and adjust our methodologies sometimes to the community, versus simply say, this is how we're going to gather the metrics, et cetera, boom, boom, boom. And then, and they're letting you know by not participating that it's not working, right? So you have to kind of have that flexibility to be able to pivot and maybe change the way you ask the questions if you're doing engaging in some kind of survey questionnaire, community-based or CAP survey, and because you want to educate, build awareness, educate, and then engage, get them to be your best advocate.
Thank you. All right. The next question is for Ed and Jay. How can the trust of medical professionals be cultivated in the BIPOC community to get information to people who need it? And I would go a little bit further and say, not only give them information, but do so in a manner that is effective for them, that is desired by people in your community. And so Ed, over to you, as you have done a ton of research with various partners.
Yeah, it's a big question, and it's a really important question, but I'm going to answer it at a micro level because I'm going to brag on my own team here for a moment. By center, we run the Medical Society Consortium on Climate and Health, and one of the programs that we run in the Medical Society Consortium is something that we call the CHEF Fellowship, Climate and Health Equity Fellowship. It's now in its fourth cohort, I believe. And it is specifically intended to train BIPOC health professionals. We started exclusively with African-American physicians from the South. We started very narrow, but we've gone more broad. We now recruit and train fellows from across the US, about a dozen per year, in unlike the Colorado Climate Medicine Fellowship Program, which is full-time for a year. This is very part-time, 1 day per month for 10 months, but it's intended to truly get community practicing BIPOC health professionals engaged, bring them up to speed, and engage them in finding ways that they can be relevant and helpful in their community on the issues of climate change as they exacerbate health inequities. And it's been it's a tiny little program, right? Our entire alumni network is less than, I guess, 60 people by now. But it's an amazing experience. It's amazing for me to see these people come in and get really fired up and not only leave and go back to their community practices to do great things, but become national leaders. Several of them are now involved in the National Academy of Medicine activities. Several are involved in other national activities. And the alumni network is it's like a fraternity or a sorority. I don't know. I wasn't in either one of those, but it has a whole lot of, they really are excited to belong to this network of fellow BIPOC health professionals who are engaging on climate and health equity. So I would suggest that we know one little approach that works, but that's a drop in the bucket compared to the importance of the question that was just posed. So let me turn it over to Jay and hear his thoughts.
Yeah, that's really great, Ed. And when we were building our fellowship and looking to expand it, as well as the diploma program, we actually, as you know, talked to the chef program and tried to work together. And we did at some levels, we did in sort of building it out. I think we had aspired to have, some overlap of fellowship. And it was, I think our models were just a little different, but I think we're looking to reengage. I think a lot of it is having an active lens, which really is, how do we make sure that it's not the people that can afford it or have the agency to show up to do our programs, but really recruit from very diverse communities, and then in turn make sure through all of our the educational networks we have in our preceptors, that we're getting back there and understanding messaging and what works and what maybe doesn't work. And I think the most important thing is to have that lens in disseminating these ideas. We call it a ribbon through all of our educational courses, to suggest that this is so important, and in that vein, bringing in the best method practices to say, here's how you do it, here's what vulnerable communities look like, here's what they need, here are the voices, and that can tell you that, and to have a situational awareness around that, because I think that's where there's often a disconnect in academia, is that you think you're like reading the textbook and you get it, and it just fails in implementation science. So I think it's just having a good deal of humility and getting as many opinions and voices as we can.
All right, we have time for two more questions, one for Renee and then one for Beth. So this next question is for Renee. We have an aspiring physician online, and he or she asked, what is the best way to integrate climate change into clinical education as they embark on their medical career?
Well, first off, congratulations. Welcome to the exciting road. And secondly, I will keep my remarks short, but I would suggest adding a climate lens to your medical education. So I don't know if any photographers out there, I dabble in it a little bit. Obviously, a lens, you just add it to the end of your camera and you sort of view everything through that lens. So recognizing climate change is the ultimate meta problem and threat multiplier, meaning it underlies problems and makes them worse, that it touches everything we do in medicine, making our jobs harder. So from an education standpoint, how can you, when you're studying the pathology of asthma, for example, how can you add a lens on understanding how does climate change impact that process now? How will it increasingly so in the future? So that doesn't mean that you have to necessarily add an enormous amount to an already overpacked curriculum. It can be a few extra slides. It can be a competency or question that's added to a problem-based learning. And of course, you can dive into courses like you've heard about here, but you can start there. And last thing I'll say, you have power as a student, knock on the door of leadership and advocate for change. Thank you.
Thank you. All right, Beth, this last question is for you. You talked about a bulging baby boomer population. Certainly all of us working in hospitals and clinics are caring for an aging population, which is a great thing. People are living longer, but they're also exposed to numerous environmental issues. And so what guidance do you have to ensure people with disabilities, so many of these aging individuals with specific cognitive or mobility needs, have access to climate change and health strategies and are incorporated in any of the planning, such as what you're doing at Providence?
Thank you for the question. And, you know, I'll answer with some of the things that have been said. So for instance, inclusion and listening to other voices is really important. And remembering that we're trying to design systems for everybody, not just for the dominant culture or people of a certain age. I think that really goes to the experts in the fields to tell us. For instance, I work with a physiatrist, and she's always reminding me of the importance of remembering people with disabilities in what we talk about and work towards. It's helpful to have the multiple voices to bring into that conversation. In terms of aging, on top of other conditions that we all have, you know, I've talked again with some end-of-life folks, and it turns out that climate grief is a reality for people who are aging too. So that's an interesting thing to bring in terms of the mental health aspects and coping as people reckon with, you know, their life and what they've left behind. I think that could be a really interesting area of conversation that could bring meaning and resolution, and also help teach younger people who are headed that way. The thornier problem, I think, is something that's part of our systems, our overly technological, perhaps, health systems that invest so much in the final days of life care. I think we can get ahead of that, but that's going to take commitment and thought and ethicists to help guide us. I hope that's helpful. Thank you.
Well, I am afraid we are at the end of our time here, but thank you to each and every panelist for sharing their expertise and for their incredible work moving the needle forward in this country and in this world. Thank you to everyone who listened. Happy Earth Day, and we look forward to the final theme and session, which is innovative research and data methodologies to address climate impacts on health.